Joining us this evening. Hi everyone, thanks so much for joining us this evening. We'll just give it a few more minutes for some other people to join and then we'll get started. Okay, so good evening and welcome everyone to tonight's webinar on understanding male fertility. My name is Paul. I'll be your host this evening. Before we kick off, I'd just like to do an acknowledgement of country. So in the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. So as I said, my name is Paul. I will be your host this evening. I have been running the andrology reception at our Melbourne clinics since March of 2021. Now, this is my first time working in the medical industry. I come from like a hospitality background, and I really enjoy creating a safe and comfortable environment for our patients. As we know, IVF can be a very daunting experience, especially at the very beginning, which is where I see a lot of our patients in the primary testing phase. I feel that helping our patients to put our patients at ease is a vital part of my role, and something that I hold quite dear and with great importance every day. I believe that sharing information and promoting education around male fertility is vital, and I'm very, very proud to be part of that process. So a bit about Monash IVF. We are a company committed to empowering the next generation of parents on their journey to parenthood. We are here for people at all stages of their fertility journey, and proudly we support patients of all genders and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about care and support that we provide our patients. Monash IVF provides world-leading scientific and medical services, and we have clinics across Australia in Victoria, New South Wales and Queensland, and sister clinics in Northern Territory, South Australia and Western Australia. So the services we offer, we provide comprehensive reproductive care. We offer everything from fertility testing through to IVF, IUI and ICSI. And of course, we can support a variety of donor treatment options. Bit of a rundown on the agenda. Today we have Dr. Cameron Sharp running through understanding male factor fertility, Dr. Dika Christie David speaking on lifestyle and male fertility, and Dr. Ross Turner running us through fertility investigations and treatments. I'll be introducing you to our speakers in just a moment. We do have a Q&A button. Our specialist will be sticking around at the end of the presentation to answer your questions. Please submit your questions through the Q&A button at the bottom of your screen, and I'll be asking our specialists at the end of the presentations. We will do our best to answer your questions. We might not get to them all depending on the timing. It's important to us to get all the information that you need. So if your question isn't answered, we do offer complimentary phone chats with our team of experienced fertility nurses. The nurse inquiry team can provide you with advice about what your next steps could be and can answer any questions you may have about your fertility journey. Or treatment. You can scan this QR code that's on the screen at the moment to book a complimentary nurse chat. Our nurse team can also help you book an appointment with one of our doctors if you wish. Okay. So whilst we will do our best to be affirming, we just wanted to mention that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities, and everyone is welcome in our clinics. The information provided in this webinar is general in nature and does not replace personalised advice or from medical professionals. Okay. So our first presenter this evening will be Dr. Cameron Sharp. Dr. Sharp is an obstetrician, a gynaecologist and fertility specialist from Bendigo here in Victoria. Dr. Sharp, he completed his medical degree at Monash University, specialist training in obstetrics and gynaecology through Monash Health, followed by a fellowship at Monash IVF focusing on infertility care. Dr. Sharp provides comprehensive reproductive care and has worked at Bendigo Health, Wonthaggi Hospital and Eastern Health, giving him a broad clinical insight into reproductive health across regional and metropolitan settings. Alongside his clinical work, Dr. Sharp is actively involved in medical education at Bendigo Health and is committed to inclusive, patient-centred care. He has a particular interest in supporting diversity and ensuring equitable access to reproductive health care for all patients. Our second presenter is Dr. Dika Christie David. Dr. Dika is a specialist endocrinologist and infertility specialist with extensive experience in reproductive medicine and infertility. After graduating with first-class honours in medicine, she completed advanced training in endocrinology at Concord and Westmead Hospitals, followed by a master's in reproductive health and human genetics at the University of Sydney. As head of endocrinology at Northern Beaches Hospital and a clinical lecturer at the University of Sydney, Dr. Christie David brings deep expertise in hormonal and metabolic conditions, including PCOS, male hormone disorders, and thyroid and pituitary disease. In this webinar, she will present on lifestyle and male infertility, exploring how endocrine and metabolic health, genetics and lifestyle factors intersect to influence male reproductive function and fertility outcomes. Our final presenter this evening will be Dr. Ross Turner. Dr. Turner is a Brisbane-based fertility specialist and gynaecologist with extensive experience in reproductive medicine. A graduate of the University of Queensland, he completed his specialist training in obstetrics and gynaecology in both Australia and the UK. Dr. Turner is currently Medical Director of Monash IVF Queensland and a Senior Lecturer at the University of Queensland. His clinical interests span male fertility, IVF, minimally invasive surgery, recurrent implantation failures and miscarriage, and fertility preservation. Dr. Turner, it's a pleasure to have you joining us tonight to present on fertility investigations and treatments. Now I'd like to hand over to our first presenter, Dr. Cameron Sharp, for his presentation this evening. Welcome, Cameron, and thanks so much for joining us.
Thanks, Paul. That was lovely. Thank you very much for the introduction. So much like your disclaimer, I just want to say that for this talk, I will be using the terms men, male to describe those with XX chromosomes, female, woman to describe those with XX. Sorry, other way around, XY for men and male. Now, that does, I do acknowledge that gender is very much a spectrum and there is nuance, but this will just help facilitate this discussion in this forum. Okay. So, why is male fertility important? Well, for heterosexual couples, it's 50% of the patient base. And with the heterosexual couples, there are 4 possible reasons for subfertility or infertility spread fairly equally between each. So 30% of couples will have just a male factor as a cause for their fertility issues. 30% will have just a female cause. About another 30% will have a combination in some way, shape, or form. And despite our best efforts, around about 10% of fertility in Australia goes undiagnosed. So the most important thing with male infertility or male fertility is sperm and the sperm concentration. Now, how do we decide what a low sperm count is? Well, this graph, as you can see, so this is a graph showing sort of sperm concentration along the bottom and along the side, the chance of falling pregnant month by month. So as you can see, sort of around about when you're around sort of a count of about 40 million, any count higher than 40 million sperm per mil, the chance of falling pregnant is about the same, around about 20% per month. It does then slowly drop off after sort of with lower numbers dropping to significantly from around about 20 million, and it's almost vertical after 15 million. So that's where we pulled our cutoff from, because that's where we do see a really marked drop off in chances of fertility, and that is also where there does tend to be other sort of concurrent pathology, other issues going on. So, as we said, low sperm count does generally sort of equate to lower chance of falling pregnant. However, this graph, this is sort of just to show that, look, a low count doesn't mean no count, okay? There is a huge difference there. So, infertility in general, there's normally only a few causes for absolute fertility, 100% not going to be able to fall pregnant without help. And that is not having an egg, not having a sperm, or the inability for those two things to mix. Everything else just lowers it. Okay, so there is still chances of falling pregnant even with lower sperm counts. It's just that it's obviously a lower chance. So for men, what does influence fertility? So it's things like age, genetics, lifestyle and lifestyle factors, as well as the fertility conditions themselves. So some of these things you can't change. They're what we call non-modifiable risk factors. Your age and your genetics, you're born with them, you're the age you are. We haven't found a way to turn back the clock yet. Otherwise, I wouldn't be bald. So what can we change? We can change people's lifestyle, and we're going to go into that later on. We can change the conditions. Now, that's things like IVF and how well will that sperm and egg meet. So to jump back a little bit, so the differences, because there are some differences between male and female fertility. So starting with female fertility, okay, female fertility tends to peak in your sort of early to mid 20s with a slow drop off up until the sort of mid to late 30s, and then a more significant drop off to 40 and beyond. And things like genetics and whether you've had a baby before, these things can affect sort of the chance of falling pregnant at different points of life. With men, so for women, very sort of slow drop, quick drop. For men, it's very much a very gradual decline in your fertility. With the most obvious, so there's no sort of, it never reaches an absolute zero. And Mick Jagger from Rolling Stones is the classic example of this, having had a baby at 73 years of age, which sounds horrible. And just because I looked it up today, so his youngest child is 8 and his oldest is 55, that's just too big an age gap. Sorry. So there is, however, there does tend to be sort of a little bit more of a drop off in male fertility after around about 40. So you get lower, you get drop offs in the concentration, the motility, or sort of the speed, so the slow swimmers, as it were, and increasingly sort of more genetic issues in the sperm that are created, mostly after the age of about 45 or so. There are some numbers that say maybe there's a few less Y chromosomes, which are sperm that would become boys or male, but that evidence is a bit more conflicting on that. So why is there a difference? Why is there a difference between men and women in terms of fertility? So women and females, so you develop all the eggs that you're ever going to make in the first 20 weeks of life. So when people are having that 20-week ultrasound where they check their fingers and toes and things like that, that fetus, okay, at that point, that's when you have the most number of eggs in your body. After that, the eggs they are all pre-programmed and they will slowly sort of die off. Okay, so the eggs sort of slowly die off to the point where by the time you hit puberty, about 75% of the eggs have already actually disappeared. By the time you get into your 20s, when you are sort of quote unquote peak fertility, around about 85% of the eggs have already gone, which is like just incredibly rude and unfair. However, I will say, even though 85% have gone, there's still about 200 to 400,000 left. So there's no lack of eggs as such. And the numbers of eggs sort of do significantly more drop off after the age sort of into the late 30s. Whereas for men, so it takes about 90 days or so to the process of creating sperm is about 90 days. And men will make around about 100 million sperm per day for most of their life. As I said, those numbers do sort of start to drop off after the age of about 40. It's just lower and less pronounced. And over time, with increasing age, the quality of the sperm also does tend to drop off a little bit. And that's where we talk about things like DNA fragmentation, aneuploidy, and those things, which is beyond what we need to talk about here, but they are just terms that, that you may hear. So, as we said earlier, the types of male infertility. So, absolute infertility or azoospermia, where there is no sperm. There's only really two reasons for that. Either no sperm is being made, so that's called non-obstructive or testicular azoospermia. And then there is obstructive azoospermia, where sperm is being made, it just can't get out. I'll go on to those two things a bit later. And then other causes, so oligospermia, that's just our long term for low sperm count. Asthenozoospermia, which is really hard to learn how to say. That is just the term for slow, for slow sperm. So obviously sperm have to basically swim their way from the upper vagina through the cervix, through the uterus, and into the fallopian tubes where they meet the egg. So fertilization in the first few days of development actually doesn't happen inside the uterus, happens in the fallopian tubes. That's why people get ectopic pregnancies. And it's only after a few days of life that the embryo comes in. So the sperm do have to swim quite a way. So motility is the other thing that we talk about. And immunologic issues, things like anti-sperm antibodies. So immune conditions where basically you have antibodies that sort of bind to the sperm itself and stop it being able to actually penetrate, get into the egg. So, as we said, there are some specific causes of infertility, which can include sort of idiopathic, unexplained. So we can't find a reason as to why sperm aren't being made despite all of our tests. There can be genetic reasons, things like Klinefelter's disease, which is an abnormal number of chromosomes. Y chromosome microdeletion, so an issue with the Y chromosome itself can manifest in the testicles, stopping producing sperm before they should. Damage to the testicles, so like trauma as a child, teenager, or adult, testicular torsion. That's why we get so concerned about testicular torsion for anyone who has sort of heard of that before. Infections, things like mumps, used to be quite an important cause for male infertility. Luckily, we vaccinate against that now, so less of an issue. And gonadotrophin deficiency. So the signals to make sperm come from the brain, and there are some causes, some things that can affect sort of the brain's ability to tell the testicles to make sperm. Reasons for obstructive azoospermia, or like a physical blockage. Obviously, vasectomy, very common. Okay, we have cut the vas deferens, which is the tube that takes the sperm from the testicles out to the prostate seminal glands and then out through the penis. And cystic fibrosis and things like that can also affect those tubes, as well as things like infection. And then ejaculatory issues, so erectile dysfunction, inability to ejaculate, or things like retrograde. Retrograde is ejaculation. All of those things can cause that more, as we said, inability for sperm and egg to mix. So the fertility conditions that can affect sperm production. So low rates of production. Look, sperm production can be sort of an indicator of overall health. So things like alcohol, smoking, drugs, high cholesterol, heart issues, use of testosterone, which I'll come to later, can all affect the sperm count. And as we said, other fertility conditions, so vasectomies, cystic fibrosis, genetic issues, like Klinefelter's syndrome, and there are a myriad of other issues. They would generally be the more common ones. So, impact of age on sperm. So as we said, look, sperm quality does decrease with age, so the genetic issues within the sperm themselves do increase. There is even a small rate increase in the risk of miscarriage if the male partner is over 45, and that's probably because of those inbuilt genetic issues with the actual sperm being made. So, diseases that are more common in fertile men. So, as I said before, sperm production is sort of an indicator of overall health. So, hypertension, diabetes, ischemic heart disease or heart attacks, these are all more common in men with low sperm counts. And that's probably because whatever the underlying cause is, so it may be issues with the actual tiny blood vessels in the body, those same things that are affecting the testicles and causing that low sperm count are also causing other issues in the body. So male fertility affects not only someone's ability to have a child, but also can give us an indicator of someone's overall health. And so there is more than just getting somebody pregnant when we see couples with infertility. And look, yeah, because look, if you're making 100 million sperm a day, medical issues will totally affect that. Low testosterone, yeah. So testosterone is required to make sperm. Okay, testosterone is made in the testicles, and that's required to sort of as a building, sort of like a building block to make sperm. Now, in particular, it is the testosterone that you make yourself that is intrinsic, that is part of you. External testosterone, so injections or even medically indicated testosterone, they don't have that same effect. You can't, if the testosterone level, for example, is low, you can't just replace that to sort of boost it up. That won't help, that doesn't help the sperm, doesn't help the sperm count. In fact, the body will recognize that there is extra testosterone in the body, and it'll say, oh, I've got too much testosterone. Like there is enough, I don't need to make more. And your own internal testosterone will drop. Sperm count actually as well will drop. Like testosterone for men has a somewhat similar effect to the pill for women. Except instead of not making eggs, you won't make sperm. Though please don't quote me on it being a contraceptive. It's absolutely not a contraceptive, but it can have that effect on your sperm that it just won't be there, and it won't be of as good quality. Generally, we'll go into that. That might be addressed later. The actual impacts of testosterone on the body long term. So, some general myths and misconceptions. So, I've had a child before, can't possibly be me. While having had children previously is somewhat protective, it probably means that you don't have cystic fibrosis and the absence of something like the vas deferens. Age, as we said, age and lifestyle factors absolutely play a part in fertility. So just because you have had a child previously does not mean that you are not the reason this time. If I've had a problem, it means I'm sterile and I'll never conceive. Absolutely, absolutely not. As we said, very few things make not having children 100%. It can just make things really unlikely. If I've had a problem, there's nothing to be done about it. Other speakers will talk about that tonight. Male fertility problems are rare. It's only me. It is absolutely not. 10% of the babies in Australia these days are born via IVF. We are just getting good at talking about in the mainstream and social media female infertility. We have barely scratched the surface in terms of male infertility. That's why we do webinars like this, try to raise awareness. We haven't really been trying, just not using contraception. Definition of infertility is regular unprotected sex not resulting in a pregnancy. Just because you're not trying doesn't mean there's not something going on. We haven't been trying mid-month. Timed intercourse is incredibly important for fertility, but it's not the be-all and end-all. I probably lack testosterone. So social media's got a lot to answer for. Just because the testosterone levels are low, it is replacement or something like that is absolutely not the answer, despite what some of the influencers out there will say. And having a low sperm count is nothing intrinsic or something that you have done. Okay, it is just something that is happening that we need to address. So I think, yeah. So what do you do if you are struggling? So first step, seeing a GP, male, female. Sometimes it's easier to talk to a male GP. Sometimes it doesn't really matter. Okay, or if you see a GP, they'll order a semen test. It's the most important thing we want to know. Get a bit of a history for you, and yes, they will ask about erections. It is very important because, as we said, we need to know all of these things. They'll send you to a specialist, gynecologist, fertility specialist, maybe endocrinologist, andrologist. There are lots of people out there. There are lots of things we can do. Okay. We cannot help everybody out there, but we can help far more than come to us. So I think that's me done. Oh, yes. This is important. We've recently sort of now got some local Australian guidelines which have recently been released. Now these are great. These are sort of, a lot of the data is specific to Australia, and it sort of amalgamates some of the really big places in the world that are doing a lot of the research, America, UK, Canada, and sort of brings all of these things together. So there are excellent new guidelines at healthymale.org where they are summarized in very easy to read language. So please go over, have a look at them. They are great. Thank you very much.
Hi, everyone. Good evening. I'm Dr. Dika Christie David. I'm based in the Northern Beaches of New South Wales, and I'm going to be talking about lifestyle factors now. So why do we need to consider lifestyle when we're talking about fertility and looking into male fertility? So lifestyle factors really can influence sperm health and the outcomes that we see when we're trying to achieve a pregnancy. And knowing about these really is important so that they can be modified if there is some need for modification of lifestyle factors, and to try and improve outcomes in terms of fertility, or if we're talking about fertility treatment, trying to optimize the outcomes from the assisted reproductive treatment that we might be using. So the things that I'm going to be talking about firstly is weight and diet, and how this can affect hormone levels, but also impacting sperm counts and motility of sperm. So that's the movement of sperm. Exercise and the importance of physical activity for hormone health, but also we do know that excessive amounts of training for females can impact their hormone profile, and for men can reduce testosterone. Smoking and alcohol can certainly have an impact on sperm quality, and we also are more aware of sperm DNA and the integrity of sperm DNA and lifestyle factors that really do impact on that. Heat and toxins are really relevant when we're talking about sperm. So it is known that so the location of the testicles is strategically placed so that the testicles are exposed to a slightly lower temperature, so cooler temperature than the core temperature of the body. So it means that if there is prolonged exposure to higher temperatures, that can impact sperm quality. So we know that prolonged laptop use, where you've got your laptop that can heat up and it's sitting on your lap, and that exposure to testicles, saunas or exposure to chemicals will all have the potential to impact on sperm production and sperm quality. And stress and sleep. So we know that chronic stress is not good for hormone profiles, and poor sleep can disrupt our hormone regulation, and of course libido, which is relevant when we're talking about fertility. So understanding all these factors is really important to optimize outcomes for fertility treatment. So firstly, diet. So it's really important to maintain a variety of nutritious foods. So fruits, vegetables, whole grains, lean proteins, these are all really important for maintaining a healthy reproductive system. We do know, and there is evidence for highly processed food having a negative impact on sperm quality. So it is important to maintain healthy eating habits, being aware of meal portions, and avoiding processed and junk foods in general. Weight and medical implications. So we use an arbitrary measure of whether somebody is overweight or obese based on their weight, their body weight, and their height. And we calculate what's called a body mass index, or BMI. And it's a way of determining whether you would consider somebody to be overweight or obese. So when we have somebody that is overweight or severely overweight, we do see impacts on other parts of the body. So impacts on blood pressure, it impacts cholesterol or lipid levels, and increases the risk of high blood glucose levels, leading to diabetes or hypertension, which is high blood pressure. So it is really important to be aware of body weight. And in people or males that are obese or overweight and experience a reduction in weight, we do see improvements in sperm function and quality. So it's really important to focus or incorporate regular exercise in addition to a balanced, healthy diet. So what specifically happens related to body weight and sperm function? So we know that there is an impact on adipocytes. So if we have increases in body fat cells, then we see an impact on physical erectile function, but also an impact on sperm quality. And that's also based on hormonal changes. So changes in estrogen, testosterone, as well as insulin, and changes in leptin. So alcohol is another really important factor. So high levels of alcohol intake is certainly associated with longer time to conception. This is relevant for men and women. So alcohol itself, of course, can have an impact on erectile function. So it can cause impotence, but also has an impact on sperm quality. So high amounts of alcohol intake regularly will impact sperm quality. So it's really important to maintain healthy levels of alcohol intake or minimize it, or if there's the potential to avoid alcohol, that's also something that's going to potentially be beneficial. If alcohol intake is excessive, then there are supports available to help with alcohol intake reduction. So smoking and vaping. So we certainly know, and it's well known about the impacts of smoking cigarettes on sperm morphology and motility. So we know that smoking does increase DNA damage to sperm, and this can cause mutations in sperm. It can cause an increased risk of miscarriages when a pregnancy is achieved. And it can also impair the health and future fertility of the child with parental smoking. So now what do we know about vaping? So because we haven't got as many long-term studies in terms of the exposure of fertility outcomes with vaping, but what we do have is animal studies. So we already do know that the components in e-cigarettes, the liquids, and vaping do have a negative effect on sperm as per animal studies. And so we would presume that this is also not helpful for human sperm function and fertility. So it is really important to aim to reduce or ideally stop smoking cigarettes completely, and to reduce or actually avoid vaping completely. And any impact or any lifestyle factor that is changed, such as smoking or vaping, will require at least 3 months without that exposure to see the impact on sperm quality. So we know that sperm turnover is about 3 months. So for men, it is possible to avoid these toxins to sperm and see an improvement, but it requires at least 3 months of that change. So what about recreational drugs? So it is known that recreational drug use will have harmful effects to the body, but specifically for sperm quality and sperm production, this is negatively impacted by recreational drugs. Performance-enhancing drugs also can affect sperm production. So it's really important to address these factors of minimizing use or aiming to completely abstain. Now, it was touched on earlier, but anabolic steroid misuse and abuse. So the use of testosterone, testosterone-related products, androgens or androgen-like products actually have a very harmful impact on fertility and sperm numbers and quality and function. So what we see when someone has been using anabolic steroids for some time is shrinking of testicular volume. So the amount of testicular tissue decreases in size. We see absence of sperm, so we can see azoospermia, or we can see a significant reduction in sperm numbers, and this, of course, will affect fertility. Anabolic steroid use can impact libido, erectile function, cause gynecomastia, which is breast tissue growth in males, and impairs the function of the testes. So it's really, really important that if you are if you're looking at pursuing fertility management and support, that you're very open about any exposure to steroids or anabolic agents, as this certainly would have some potential to impact sperm function and numbers. So the reason behind this is is based on the hormone profile that we have. So you would think that, okay, well, if I'm exposing a sperm to more testosterone, and we need testosterone for sperm function and production, then shouldn't it help? No, it doesn't. So our endocrine systems, which are our hormone systems, are feedback systems. So there is the hypothalamus and pituitary in the brain, which secrete hormones that stimulate the testicles to produce sperm and to produce testosterone within the testicle. Now, what happens is if you are exposing your system to testosterone or something that acts like testosterone, it blocks off that pathway. And then it leads to a reduction in sperm production within the testicles and testicular production of testosterone. So that is the cause. So we call this hypogonadotropic hypogonadism, which is where that axis of pituitary hormones is blocked off. So taking steroids stops the body's own production of testosterone. When you stop steroid use, it does take some time to see a recovery. With enough time, we would hope that there is a recovery, but it can take weeks to months to see an increase in endogenous or the body's own production of testosterone again, and to see an increase in sperm production. Now, that process of coming off anabolic steroid use after having used these agents for some time is really, really difficult. It's a very uncomfortable experience for that person. They would experience symptoms of withdrawal, mood changes, cravings, and this is an area that can be really challenging, because that person who has been used to a certain amount of hormone levels now has to come off that agent for the sake of improving endogenous or their own body's testosterone production and sperm production. So this is really important to know about if somebody's looking after you and helping with your fertility. It's really important to share that information with your doctor. So environmental factors. So what are the other things that you could be exposed to that could have an impact on fertility? So prescription medications, important to review that with your doctor as to whether there's any of your medications that could be having an impact on sperm function. Finasteride is a medication that's commonly used to manage male pattern hair loss. It can, in some situations, have an impact on sperm numbers and volume of semen. And there's a syndrome that's not common, but finasteride syndrome, coming off the finasteride, and some of the symptoms that can be experienced, like low libido. So it's important to just review whether it's necessary to come off your finasteride if that's something that you're taking. Pesticides and industrial chemicals that might that you might have been exposed to in the past, or that you were exposed to related to work, or other potential exposures that might be industrial. So these could have an impact on sperm quality, so that's important to know about. And as I said earlier, so temperature around testicles, so the effect of keeping your laptop on your lap for extended period of time, excessive heat, so things like saunas or hot temperatures for prolonged periods. We see it with men that engage in a lot of cycling. So if there's a lot of cycling, and that heat exposure and impact on testicle temperature can in fact have an impact on sperm quality. So being aware of these things is important. So what are some other strategies to protect male fertility? So generally speaking, there are some things that can have an impact on testicular function and sperm. And one of those is mumps virus. So mumps virus, which we are now vaccinated for widely, reduces the chance of people experiencing mumps virus infection. But mumps can cause orchitis, or inflammation or an infection in the testicular tissue, and that can have ongoing impacts on sperm. Environmental factors and compounds that are found in plastics, and what we're starting to learn more about, endocrine disrupting chemicals. So chemicals that we're exposed to day to day in plastics, pesticides, various cooking equipment. We're realizing that these can interfere with production and action of hormones. So what about some natural remedies for male fertility? So look, I wouldn't say that it's compelling evidence that you should be taking all of these supplements or consuming all of these things, but there is some suggestion that consuming things that have beneficial effects on oxidative stress and that are antioxidants can have some potential improvements in sperm quality, and that's to do with that underlying DNA integrity of sperm. So natural things are things like garlic, green tea, goji berry, as these are contain antioxidants, ashwagandha, maca root, flaxseed oil. They have been seen to reduce oxidative stress. Taking huge amounts is not what I would recommend, but certainly these are the types of natural things that are not going to be harmful and maybe of some benefit. And so generally, nutrition for sperm quality could include things that, again, consist of antioxidants. So walnuts, oily fish, zinc, folic acid. So as I said at the beginning, healthy diet, maintaining a balance, but these are some of the things that you might incorporate. So what about supplements? So there is some evidence that taking zinc, coenzyme Q10, and vitamin E, have a positive effect on sperm integrity. So these can be found in combination or could be taken separately as supplements. If there are deficiencies in your diet and your diet is not balanced, then a multivitamin can be helpful. But these taken in appropriate amounts that you can find in supplement quantities are appropriate, but excessive amounts is not what I would recommend. So finally, really important to maintain a healthy lifestyle, balanced diet, sleep, and managing stress is also really important. Being aware of some supplements that can be helpful for sperm quality is useful, but supplements and diet changes and the items that I've mentioned just now are not going to override factors like smoking, excessive alcohol, lack of exercise, and it's really important to be aware of those factors. So really important to be assessed and examined if there is the potential for some reversible factors that can be addressed to improve sperm quality and fertility outcomes, and really important to understand these lifestyle factors to improve fertility. Thanks.
Good evening. My name's Dr. Ross Turner. I'm located in Brisbane, Queensland, and I'd like to welcome you all to this webinar, and I hope you've been finding it interesting and informative. My talk is about fertility investigations and treatment. And one of the questions, it is important to take steps to understand your reproductive health before embarking on fertility treatment. As already mentioned tonight, whenever there is a problem with infertility, there's a misbelief that it's mainly female, but as Cameron has already pointed out, in 50% of cases, there is a major male factor in the cause of the infertility. And as he has already stated, in about a third of cases, it's mainly male, a third of cases, it's mainly female, and a third is a combination of both. This is not a blame game. This is mainly to point out that it's very important, if there is a fertility issue, both partners need to come along to be assessed. Why is it important for men to know about their reproductive health? Mainly because in the general population, 10% of male will have a fertility issue, and they will not know about it until they're tested. And of those 10%, another 10%, so that is 1% of all men will have no sperm in their ejaculate. And apart from when they have trouble achieving a pregnancy with their partner and get tested, they'll be unaware of that. The other advantage of knowing about your reproductive health is that it is associated with other health issues and genetic problems. And if these are identified, appropriate interventions are taken, then that can prevent disease occurring later in life, leading to a better quality and a longer life. So, when we look at reasons to assess the male partner, questions we are asked is, can we give a reason why I've got a fertility issue? Can we restore natural fertility? Are there other health problems? Are there genetic problems? And what is the success and safety of assisted reproductive technology, both to the patient and to the offspring? Addressing the first two issues, while in most cases of male infertility, a cause cannot be found, frustratingly, the cause with the most successful treatment is the least frequent one. That is where you have inadequate production or no production of the hormone from the pituitary gland that stimulates the testes to produce sperm. However, with medication, which entails injections of that hormone 2 or 3 times a week for 3 to 6 months, fertility can be restored back to normal. The most common cause of infertility is, in fact, decreased production in the testes. Now, sometimes there's an obvious reason for that, such as the male has had chemotherapy or radiation, or has had major surgery or trauma to the testes, explaining why there's no sperm production. But in most cases, no cause can be found. And we think in this situation, it is most probably genetic. It's estimated that there are about 2,500 genes that help control sperm production. And of those 2,500 genes, we can test for 3 of them. And the three genes we test for is the AZFA, AZFB, and AZFC genes. And it is important to test for those because not only does it give a reason for the abnormal sperm parameters, but also it has prognostic significance on whether actually sperm can be retrieved from the testes or not, and also if there's a risk of passing on the fertility issue to the male children. Another common cause for lack of sperm production is Klinefelter syndrome, which has already been mentioned. This is where there's an extra X chromosome, so the male has 47 XXY. Generally, they're tall. Generally, they only find out about this. It's usually misdiagnosed until they're in trouble with fertility, and they do a sperm test, and it's very low or no sperm in the ejaculate. It's important to diagnose that because these men invariably have low levels of androgens or testosterones. And as mentioned tonight, once their fertility treatment is finished, it's very important they go on testosterone replacement to make them feel better, increase their well-being, and also prevent the onset of osteoporosis and cardiovascular disease, which they're prone to. Other Potential causes of infertility is an obstruction to the sperm. And the obvious one for that is a vasectomy. And these men can either undergo a vasectomy reversal or have sperm aspirated from their testes and use IVF to create embryos and hence pregnancy. The other one, as already mentioned tonight, is bilateral congenital absence of the vas deferens. And it's very important that that is diagnosed. For those men, they generally have 2 gene mutations on the cystic fibrosis gene. So they, in fact, technically have cystic fibrosis. But usually it's one major gene mutation, and then the other gene mutation is a minor one. It produces enough protein so they don't have the signs or symptoms of classic cystic fibrosis. The problem being is that we can aspirate sperm from their testes, we can create embryos, but if their partner has a cystic fibrosis gene, mutation, they have a significant risk of having a child with cystic fibrosis. And in fact, the chances of carrying a cystic fibrosis gene mutation is 1 in 25. So it's quite a significant risk. So it's very important, if you diagnose bilateral congenital absence of the vas deferens, that the female cystic fibrosis gene is closely analysed to see whether she carries a gene mutation. The other reason to diagnose that is that these men, in 10% of cases, may have actually renal abnormalities, and they may be missing a kidney on one side. Also, the presence of a varicocele, that can raise the temperature in the testes, as already mentioned tonight. High testicular temperature affects the sperm production and the quality of the sperm, and by correcting that, fertility can be reversed. Another cause of obstruction, which is less common, is a little cyst in the ejaculatory duct, which is up near the prostate. And by having that resected, the blockage can be overcome and fertility restored. There are other ones which we won't cover tonight, such as we already mentioned erectile and ejaculatory problems. So, are there other health problems? Certainly there is. We know that men with significant male factor infertility have an increased risk of getting testicular cancer. Not high enough that it's recommended to have routine screening, but certainly recommendations to do self-examination, and if they find a lump developing, to go and have it analysed. Also, as already mentioned, they have an increased incidence of getting cardiovascular disease and metabolic disorders, such as high blood pressure, diabetes, and increased lipids and fats in their blood. So it's very important they connect with their GP, have these investigated, appropriate management to decrease the chance of getting later onset disease. Just suffering from a bit of Queensland heat here at the moment. Also, as mentioned, some men with male factor infertility have testosterone deficiency, and they'll benefit from testosterone replacement therapy after they finish their fertility treatment. Being diagnosed with male factor infertility sometimes can be very confronting, particularly if there's no sperm there and they're looking at the option of doing donor sperm. And sometimes they can have severe psychological effects, and there is counselling available. Are there genetic problems? Well, as already mentioned, there are on the Y gene deletions causes for male infertility. There's a possibility of having a karyotype chromosomal abnormality, such as Klinefelter syndrome, and also being affected with the cystic fibrosis gene mutation. Excuse me. Also, there is some data which suggests that male offspring from ICSI cycles done for male factor infertility may they themselves have fertility issues. While there's no increased risk in congenital abnormalities, there is an association with some minor genitourinary abnormalities, such as hypospadis. And that's where the urethra doesn't open at the end of the penis, but on the undersurface of the penis. And that can be corrected sometime after birth. What are the success rate and safety of ART? The success rate of IVF closely follows that of the female. So, as already pointed out, the natural chances of conceiving in a female up to the age of 30 is about 25% per month, dropping to 20% per month by the age of 35, down a more precipitous drop to 10% by the age of 38, down to about 5% by the age of 40, and less than 1% by the age of 45. And the success rate from IVF, unfortunately, follows the same decline. In ladies under the age of 35, having up to 3 IVF cycles, they have over 70% chance of taking a live child home. While between the ages of 35 and 39, the chance of taking a live child home is a bit over 50%. Between 40 and 44, it drops down to a bit over 20%, and over 44 down to about 2.5%. Now, if surgically retrieved sperm, that is sperm that's obtained from the testes either by aspiration or from biopsy, there is a slightly lower success rate, but not much lower. Is ART safe? Unfortunately, all the burden of fertility treatment generally falls on the female because we have to access eggs. We want to get a good number of eggs, and she has to undergo an egg collection. One of the biggest complications in the past from stimulation was ovarian hyperstimulation syndrome, where they got very ill and potentially could die from that condition. However, these days, with modern stimulation and different triggers and close watching, that condition is pretty much eliminated. Is IVF safe? The other problem is egg collection. That's generally done under a general anaesthetic. So there's a small risk of having adverse reaction to the general anaesthetic in the range of like 1 in 10,000. Like any surgical procedure, there's the risk of infection, bleeding, damaging other organs, or because the ovary is grossly enlarged from the stimulation, it can twist. But putting all those together, all those complications occur less than 1% of the time. Is there any risk to the offspring? Certainly IVF is associated with 1.5 times higher congenital rate than the general population, but interestingly, the same incidence as in infertile couples who conceive naturally. So the background chance of having a child with a major congenital abnormality is about 2 to 3%. If you do IVF or you conceive naturally and you have infertility issues, the rate is about 3.5 to 4.5%. Reassuringly, there's no consistent abnormality, which would suggest that maybe it's not so much the treatment, but the people who we are treating. The other issue is a very rare condition called imprinting disorders. You might read about that. The incidence of them in the general population is about 1 in 30,000. With IVF, it may increase to 1 in 10,000 or 1 in 15,000. It's very hard to prove that because it's a very rare condition. Doing IVF sometimes, particularly with male factor infertility, they have to do ICSI, where they have to inject the sperm into the egg. And it is associated with a slightly increased chance of a child being born with a sex chromosome abnormality, such as an extra X chromosome, Klinefelter syndrome, as already mentioned, or in Turner syndrome in a female, where that X chromosome is missing. It's thought that the original data showed that the background rate of that in the general population is about 0.2%, so 1 in 500 babies. If they have ICSI, you can get as high as 0.8%, so 1 in 4 in 500 babies. Now, that's old data, and that might be because when ICSI was first developed, we weren't closely doing the chromosome analysis on the men, and some of these men might have had sex chromosome abnormalities such as Klinefelter syndrome. The other risk of IVF is, of course, cystic fibrosis, and that's why it's very important that if you diagnose bilateral congenital absence of the vas deferens, that to make sure the partner has very detailed cystic fibrosis gene testing. So what is the fertility health assessment? This basically entails both partners going along to their GP or being referred to a specialist, detailed history and examination, appropriate investigations, waiting for those results to come back and having a review consultation to review the results and then determine what treatment can be undertaken. Can we move on to the next slide? There. So as mentioned, both parties come along with the detailed history, mainly focusing on the male tonight. You want to know the age of the male. Has he had any previous pregnancies? How long it took him to achieve those pregnancies and the outcome of those pregnancies? You want to know about any problems of intercourse, so if any problems of erection, ejaculation, or penetration. Has he had any history in the past of genital tract trauma, infection, surgery, exposure to drugs, and also the exposed to anything nasty to the testes, such as high temperature, radiation, chemicals, drugs, particularly anabolic steroids, as already mentioned tonight. We want to know if there's any other medical or surgical problems that might affect his fertility or general health. A family history, particularly of any genetic problems running in the family or fertility problems. What medication he is on, and again, stressing being honest about taking anabolic steroids, because that has big implications for your health. Smoking and vaping, as already mentioned, and alcohol use, and the amount of exercise they do. Then it comes down to the investigations. And the initial investigation for the male is a seminal fluid analysis, and we'll talk more about that later. And that results from that may lead to further investigations such as blood tests, looking for hormonal assay, the Y gene deletions, doing the chromosomes, or a scrotal ultrasound scan to assess any abnormalities in the testes or the scrotum. Next slide, please. I think there. So I thought there's a slide missing there, but one of the things we will talk about is genetic carrier screening. The other one was immunisation. It's recommended that the male keep up to date with his immunisation, mainly for the influenza COVID virus and also whooping cough, because whooping cough is more prevalent in young neonates, common, and if they do get infected, they can die from it. And the most common source of infection is either a parent or a close relative. So it's important to have your whooping cough vaccine updated. Genetic carrier screening, I think this is very, very important. This is basically looking for gene mutations that you may be carrying that you're unaware of. So we inherit 2 copies of each gene, one from our mother, one from our father. On our chromosomes, there are about 20 to 25,000 genes that produce proteins that make our body work. And it's estimated that we all carry at least 3 to 5 recessive gene mutations. And by recessive, we mean that both genes you inherit have to be abnormal to have the disease. It's only a problem, however, if your partner has the same gene mutation. And problem with having a single gene mutation, you're known as a carrier, is that generally you don't know you got that gene mutation. Even if you had previous normal children, doesn't mean that you don't both carry the same gene mutation, and often there's no family history. It's only when you go to reproduce, when you produce your sperm and eggs, normal gene goes to one sperm, abnormal gene goes to the other sperm, and same with the egg. And if the gene in the sperm and the egg with the abnormal gene get together, then the baby's born with no normal working gene. The 3 most commonest conditions are cystic fibrosis that occurs in 1 in 2,500 children in the community. They have lots of chest infections, poor absorption from the gut, multiple admissions to hospital, and a shortened lifespan of about 30 to 40 years, though that is increasing with modern therapy. The other most common one is spinal muscular atrophy that occurs in about 1 in 3,500 children, and they die in the first few years of life from nerve degeneration. And Fragile X, which occurs in 1 in 6,500 boys, is the most common cause of severe male mental retardation. Now, the government will fund 3 gene testing for those 3 genes, and the way it's set up is the lady gets tested. If she's found positive for one of those genes, and the male gets tested. There is a 0.5% chance of a match. So 1 in 200 couples, if they do the 3 gene test, will find out they both carry the same gene mutation. Monash does have a more extensive gene testing. We test for over 400 genes. It does cost a little bit under $1,000. It's a fairly easy test to do. You can order it online. They send you the kit, which is basically just a mouth swab. You send it back. And if you do that, there's a 2.5% chance that you have a match. If you are found to have a match, there's your genetic counselling available for you. And also one of the choices is that you can do IVF, create the embryos, test the embryos, and only put back unaffected embryos, therefore avoiding a very sick child. And in fact, these recessive conditions is the commonest cause of a baby dying or death in the early childhood, and a commonest cause of admission to a children's hospital. So I think it's very important, and it should be offered to everybody, and you should seriously consider doing it. The other fertility investigations, immune status I've talked about. We do check for infectious diseases. This is the common syphilis, hepatitis B, Hep C, HIV, and also chlamydia and gonorrhea. And the other important test we do, and probably the most important test for a male, is the seminal fluid analysis. So with the seminal fluid analysis, there's a few points about this. The recommendation is to abstain for at least 2 days, but no more than 5 days. Stored sperm go off. You have to collect by masturbation, can't use lubrication. It's got to go into a sterile jar. As a rule, you've got to book into it, particularly with the IVF laboratories, because it takes a scientist up to 1 or 2 hours to do all the assessment. And it's got to be there for 1 hour of production. However, most laboratories will have a room that you can produce in if you can't get there within an hour. And what they look at is the ejaculate volume, the sperm concentration, the motility, the sperm count. Sperm antibody test, as already mentioned. These are immunological substances that the body can produce. They bind to the sperm and they can interfere with the passage of the sperm's passage through the female genital tract and also interaction with the egg. And the other big one is sperm DNA fragmentation. Those last 2 tests, sperm antibody test and sperm DNA fragmentation, aren't part of the normal routine testing in a general laboratory, and they're generally done by a specialised IVF laboratory. The importance of sperm DNA fragmentation is becoming more relevant as more knowledge is attained on it. Certainly, if there's a high levels of sperm DNA fragmentation, there is reduced chances of conceiving naturally. One of our fertility treatments, a simple outpatient procedure treatment called intrauterine insemination, has a very low success rate if there's a high sperm DNA fragmentation present. If you do IVF, there's lower fertilisation. So in fact, we'd recommend ICSI. Rather than allowing the sperm to swim around and fertilise the egg, a single sperm is picked up and injected into the egg. If there is decreased embryo development, so these embryos generally grow old to about day 3, and a lower percentage than normal go through to the day 5 blastocyst stage. And if they do fall pregnant, there's increased risk of miscarriage. So I think with increasing knowledge about the effects of sperm DNA fragment, this will become part of the regular seminal fluid analysis. So looking at the values on the next slide, this is looking at sperm morphology. You can see you can have different types of sperm. You can have double-headed sperm, one there swinging down there on the right. You have 2 tails. You can have abnormalities of the head piece, the mid piece. And it's very important to assess the sperm morphology. Men are very good at producing lots and lots of sperm, but not very good looking sperm. And we know that if the percentage of normal sperm drops below 4%, the fertilization rate in IVF drops from about 60 to 80% down to 8%. So it's very important the sperm morphology is closely assessed. The other thing about a sperm test is that it doesn't predict your fertility unless there's no sperm there at all. As already mentioned, that men with normal sperm counts may have no trouble may not be able to achieve a pregnancy, while men with very poor sperm counts may be able to achieve a pregnancy. And we never trust one seminal fluid analysis that's abnormal. We always repeat that, generally about 6 to 12 weeks later, because already mentioned it takes about 3 months for a full sperm cycle to occur. So if we look at the parameters, you may find these a little bit different to what you read in the literature. These are the new 6 WHO sperm criteria that have just been recently published in the last year or 2. So on the semen volume, we want a volume of greater than 1.4 mils. Sperm concentration, greater than or equal to 16 million, used to be 15 million. We're looking at the motility. We want at least 42% of sperm showing some form of motility, and we want 30% of them swimming forward. And looking at the normal forms, we want that to be greater than or better than 4%. And as already mentioned, test on 2 occasions if it's abnormal, and it's more, doesn't tell us about the fertility. It's more, it gives us an idea on what treatment is suitable for this particular couple, and also if we are doing any intervention to try and improve sperm counts or DNA fragmentation, repeating the test tells us how the treatment is working. The other part of the initial consultation is a physical examination. I think I forgot to go over that, but certainly after you've taken a history, you want to do an examination. So we would want to know the guy's height. That's particularly looking for things like Klinefelter syndrome, their weight, looking for the effects of obesity, their blood pressure, because there's an increased incidence of hypertension in men with male factor infertility. Then we look for the normal secondary sexual characteristics. And these are things like muscle distribution, male distribution of hair, deepness of the voice, the big Adam's apple, the absence or presence of breast tissue, any masses in the tummy, and then we do a genital tract examination. And part of this is we assess the size of the testes. We use an orchidometer. It looks like a necklace beads that some ladies might wear, but not after they find out what an orchidometer is. And we assess the size of the testes. And a normal mature testes is somewhere between 14 to 20 mils. And it's a good correlation between testicular size and the amount of sperm production. We also feel for other abnormalities such as masses, as already mentioned. Men with male factor infertility have an increased incidence of testicular cancer, the presence of any cysts, if the vas deferens is present, if there's varicose veins present, because if varicocele are present and are significant, and there are abnormal sperm parameters, having the varicose veins fixed may return fertility back to normal. We check the groin to see any previous surgery, particularly inguinal hernia repairs, because not often, but sometimes the vas deferens, which is the tube that drains the sperm from the testes to the outside, can be damaged during that procedure. So what treatments can we have for male factor infertility? I think one of the most important is lifestyle changes. That's already been mentioned. And what we know is that men should cut out illicit drugs, stop the smoking and heavy alcohol consumption, a healthy diet, so plenty of fresh fruit and veggie, natural antioxidants in the form of nuts and berries, reduce the amount of animal protein, more plant-based protein, a diet high in folic acid, omega-3, a low GI diet, and full cream milk in the big study in America was also shown to have a higher association with success rate with IVF. Antioxidants and vitamins has already been mentioned, and I think particularly if there are abnormal sperm parameters, it's worthwhile to take those. If there's any female factor present, particularly if the lady is not ovulating regularly, you want to get her ovulating. And one of the simple treatments is intrauterine insemination. This is a outpatient procedure, fairly low key. It's suitable if there's only mild male factors or minimal mild endometriosis, or unexplained infertility. So there are the three fertility treatments fertility indications that we recommend for this. To do intrauterine insemination, the lady has to be ovulating. So if she's not already ovulating, be able to induce ovulating. You need at least one open fallopian tube, because as Cameron already mentioned, to have a baby, you need sperm, eggs, and they've got to meet. And then you need a good number of sperm. And after a sperm prep, we like to have at least 2 million motile sperm, somewhere between 2 and 20 million motile sperm. If all those criteria are met, it's a worthwhile thing to do, particularly if the lady's under the age of 35. And success rate is about 10 to 15% per cycle, with most people who are going to fall pregnant conceiving within the first 3 or 4 cycles. So about a third of couples will conceive from that. If that's unsuccessful or if the other sperm parameters are worse, you may need to go straight to IVF. And that's a process where the lady undergoes stimulation to recruit a good number of eggs. We aim for somewhere between 10 to 15 eggs. On the day of egg collection, the male produces a semen sample that's processed. So the most motile and best-looking sperm are isolated. And if the sperm parameters are fine, they're mixed with the egg and natural fertilization will occur. The embryos are then cultured out to day 5 when they reach the blastocyst stage. And if so, there's no contraindication to a transfer. An embryo is transferred and excess embryos are stored for later use. If, however, the sperm parameters are very poor, such as low numbers, low motility, very low percentage of normal-looking sperm, or in the high presence of a large number of sperm antibodies or high DNA fragmentation, we'd recommend ICSI. That's where a single sperm is picked up and injected into the egg, hence leading to fertilization. And as already mentioned, the success rates usually correlate to the female age, with surgically retrieved sperm having a slightly lower success rate. So steps, one is referral from your GP to see fertility specialists. I can't stress the importance that both partners come along, because fertility is a couples issue. After the initial consultation, where detailed history and examination is done, tests are ordered, we then get you to come back once those test results are back to go through the test results and plan the future treatment. Thank you. And I think now it's time for questions.
Okay, thank you for those presentations. Lots of great information in there. So we have had quite a bit of questions come through. So we'll run through those. Unfortunately, we won't be able to get to all of them this evening, but we'll do as many as we can. First of all, I'd like to open up our first question to Dr. Dashika. In regards to the lifestyle factors impacting quality of sperm, how long do these factors impact sperm quality for? For example, would excessive sauna use for 3 months ago, for example, affect sperm quality today?
Yeah, so like we were talking about in terms of sperm turnover, so it's about, I mean, technically speaking, it's about 70 something days, but we say, all right, if you're going to make changes, we need to you need to implement those changes for at least 3 months, so that the sperm that we're going to be using, say, for fertility treatment is going to be the best quality. So if it's something like smoking cigarettes or alcohol exposure, and there's been a change in that or cessation, then you would want to give that 3 months of continuing with that to see the full impact or the benefits. If it's something like heat exposure, so we know that there's the impact of things like we were talking about before, like saunas and using them excessively, or if it was frequent use, that sort of impact, I mean, you would think it's 3 months, but it's probably a little bit longer, like 3 to 6 months that you would want to give it to see a complete improvement or resolution of the impact of that heat exposure on sperm numbers and quality.
Perfect. Thank you so much. We did actually have a question that was relating to alcohol consumption and smoking as well. So thank you for touching on that. I hope that answered that person's question. Dr. Ross, I'm going to direct the next question to yourself. Can sperm selection for IVF include the possibility to achieve twins or multiple fertilized eggs at once?
Certainly we only want one sperm in fertilizing one egg. Otherwise, that can lead to an abnormal embryo. But I think the question might be, will we do more than one embryo transfer? Australia, and particularly Monash, has led the world in reducing the incidence of multiple embryo transfers, because the risk of that is a multiple pregnancy. And while that sounds good, we know that 10% of twins will deliver before 32 weeks, sometimes a lot earlier than 32 weeks, and that carries significant risk of the babies not surviving or surviving with severe abnormalities. So we try to reduce the incidence of multiple pregnancies. In fact, we look on it as an adverse pregnancy outcome in our success rate meetings. So we have a strong pressure just to do a single embryo transfer. Even in that situation, when we put back one embryo, one blastocyst, there's still a 2 to 3% chance it can split into a twin. And that'll be an identical twin. We can't prevent that. But certainly, to answer the question, we only want one sperm fertilizing one egg. Otherwise, it'll be an abnormal embryo. And when it comes to embryo transfer, we strongly recommend just a single embryo transfer to avoid a complication of a multiple pregnancy.
Perfect, thank you. Dr. Ross, you also touched on what's included in a standard semen analysis. But could you maybe say a little bit more on what does it mean if the results vary between tests, if a patient's done multiple testing?
Yeah, the testes don't have a steady production day in, day out. And we know that there was actually many years ago, there was a guy who was asked to produce a semen sample every week for a year. And actually the sperm numbers, they just went up and down quite dramatically. Sometimes 20, 40 million sperm per mil. Next month, it might be down as low as 10 or 12 million sperm per mil. So there's quite a lot of variation between testing. That's why we always ask for a repeat test. As mentioned, a seminal fluid analysis doesn't predict your fertility unless there's no sperm there at all. because men with very low sperm counts, very low motility, can still have successful pregnancies, while men with perfectly looking sperm parameters just can't achieve a pregnancy.
Okay. Dr. Cameron, I might direct a question to you, the next one. Can lifestyle changes alone ever be enough to restore fertility in men with mild subfertility?
Yeah, look, so it's a good question. Lifestyle changes are 100%, like they're the first thing that we'll go to. They are the easiest to implement, and they can show good impacts for mild male factors. So that's sort of that sort of slightly low count. So, we said sort of we want about 15, 16 million per mil. We're talking sort of double digits, but below what we would call normal. And quite often they are quite good, particularly things like smoking, alcohol, drug use, or testosterone use. The cessation of those things can have pretty good impacts on sperm count and motility. The question's right also to sort of specify that sort of that mild. So, for example, if you've got a really significant amount, deficiency in the sperm count, that's not necessarily going to be addressed. However, we are still going to recommend all of those things because they are going to have some impact, and a lot of these things are sort of great for overall health, because not only is somebody trying to get pregnant, but they are presumably also going to want to be a father for the next 20 plus years.
Thank you for that. Now, look, if a man, I'm going to stay with you, Dr. Cameron. If a man's sperm count is low but not zero, you mentioned all those lifestyle changes that you can do, but what are the most effective treatment options available?
Yeah, so Dr. Ross had gone over some of those things in his talk. So it sort of depends a little bit on whether we can find a specific reason. Is the specific reason, for example, anabolic steroid use that can have profound effects? Reversal or cessation of that can significantly improve things with time and not always 100%. Other things, the other things that we can use for sort of that more moderate factor are things like IVF or IUI. So not so much for that sort of pretty significantly low count, sort of those counts below sort of 5 or so, because we need to get a certain number of sperm basically concentrated. I describe it, it's really gross, but you're basically really trying to sort of concentrate the sperm almost into a pellet and just putting it in the right place at the right time. And so you do actually need a decent amount of sperm there regardless. So it's not the best thing for those really low counts. In those cases, the thing that was like, the thing that you need is IVF with ICSI. So with the individual taking a sperm, putting it into an egg, which was an absolute game changer about 30 years ago. Prior to 30 years ago, before we had that, really low sperm counts just didn't work. That was being able to pick up a sperm and place it and sort of inject it directly into an egg, which is exactly the thing that they always put on TV to talk about IVF. Absolute game changer and revolutionary.
Yeah, perfect. Thank you. Just one final question before we wrap up, and I'll open this up to anyone. Is it true that the second ejaculation of the day has a far higher quantity and motility of sperm than the first?
I'm going to jump in there. I think I forget to mention in my talk that ways to improve your natural fertility is frequent ejaculation. What we know is that stored sperm do go off. However, repeated ejaculation is associated with lower volume, lower numbers, lower motility maybe, but certainly better quality sperm with less DNA fragmentation. And in fact, at Monash, we're looking at whether changing our usual advice of abstaining for 2 days prior to a egg collection, whether the guy should ejaculate the night before, the morning of, and then another ejaculate for the treatment cycle. There is some data saying that gives you better quality sperm. So I think for people who are looking at natural conception, storing up sperm, avoiding intercourse for a week before the fertile time is a bad thing to do. You're going to have poorer quality sperm. And I think the more troops on board, the better chance of falling pregnant. And certainly around the fertile time, should have intercourse at least every second day. The other question is, which I didn't touch on in my talk, is, and I think the previous question might have been alluded to, is it worthwhile any medical treatment to improve sperm numbers? And unfortunately, there's not much research on this in the past, but at the moment, Monash is conducting a study looking at whether any medical treatment will increase sperm numbers. There is a bit of interest around worldwide. In the past, it was always thought that men with very low sperm counts giving medical treatment in the form of tablets or injections, if it did increase sperm numbers, it didn't increase it enough to change their treatment option. If they're very low sperm numbers, they still stayed very low and they still needed to do ICSI. However, there's a lot of research going to that. So that field may change over the next 5 years.
Wonderful. Thank you very much. That's all we've got time for today, unfortunately. So we're sorry we couldn't get to all the questions that came through tonight, but we do encourage you to scan the QR code that was in the presentation and that should be coming up shortly as well, for a complimentary nurse chat with one of our experienced fertility nurses, for personalised guidance about your options. So that's a really important thing that service that you can use from Monash. So we encourage everyone to do so. Thank you all for attending, and we at Monash wish you the very best for your fertility journey. Thanks so much.
Thank you and good luck, everyone.
Not all.